Hi, welcome to my channel. My name is Lisa Alistway, and on this channel, you will find a variety of inspirational and informational videos you can use and apply to your life. My guest today is Dr. Chris Johnson, who is an emergency trained physician and is a nationally recognized expert on the opioid and heroin epidemic. I will be linking his website in the opioid crisis in the description box below for your reference. Welcome, Dr. Johnson.
And good morning. Thank you for inviting me.
Yes. So could you just share with us a little bit of your background and how you got into really studying and researching and talking about this opioid and heroin crisis?
Okay, well, my background is emergency medicine, and my decision to look more into the opioid crisis and become something of an advocate was purely accidental. I did not set out to do with any of this at all, to be honest with you. I trained in emergency medicine at Hennepin County Medical Center here in Minnesota, and then I went to work at a suburban hospital, community hospital of Minneapolis. And it was there that I made the realization that we've got a very serious problem. And this is around 2004, 2005, so quite some time ago. Now, when you're training as a resident physician in a county hospital, you do see quite a bit of social pathology. A county hospital, these are often teaching hospitals, and it has a teaching hospital population often has a lot of patients who come from, difficult social backgrounds, families that have been distorted with, crime and incarceration, and often that goes with mental health problems that go untreated, and that can often correlate with problems with substance abuse. And so I actually saw quite a bit of that as a resident physician, but I thought I was sort of all done with that when, like, you finish your residency. I mean, for those who don't know medicine or don't, you do a residency as like an apprenticeship, and that's sort of for a defined set period of time. And then you move to some other more regular job as a physician. And so after my 3-year residency in emergency medicine, I went to a suburban hospital and I took a job there in a community. And I kind of had thought that the amount of substance abuse issues and opioid issues, which I'd seen plenty of, was going to be behind me. But that's not what I discovered, okay? When I went to work for this suburban hospital, I found that I couldn't go a shift without seeing someone having some complication from opioid use. And this was what wasn't often heroin, it was prescribed opioids. And they were, again, it was not just me, every physician had this issue. They were having one or more patients with those problems, whether they were overdosing and had to get put on a ventilator, or whether they needed Narcan, which is the opioid antidote, or they were coming in with pain and they'd run out of their opioids and they needed more. And so that's what spurred me to investigate. Okay, I thought this was behind me. I thought this was different. And it's like, no, this is everywhere. And so it became one of my crusade, but one of my tasks to find out, why did this happen? Why is it happening here? How did it happen? And what do we do about it?
Yes. Before we answer those questions, can we back up and just define what opioids are and what they do for the body?
Opioids are a category of compounds, of medicines that, originally the name comes from something called the opium poppy, okay? And that goes back about as far as we have written history. And was used as a medicine that could treat pain going back, the Greeks, the Assyrians. You could harvest it from the flower, the opium poppy, and take the milk or juice from that, and that would have morphine in it, and that will bind the opioid receptors in your brain, and it will deaden the experience of pain in a couple of ways. One is it blocks the transmission of pain, but it also makes you feel good, okay? And by doing that and elevating your mood, it will reduce your suffering from pain. And so it has this effect of reducing the suffering from pain. And but at least temporarily. It doesn't continue that way, but temporarily. And And remember, opioids are compounds you make yourself. You know, these are your endorphins, all right? These are natural compounds.
Yes.
You know, unless you made this yourself for some particular reason, your brain wouldn't have a receptor for it, okay? But your brain does. You make this, okay? So those are all opioids. And the more common prescribed opioids that your audience may have heard of would be Percocet, which has the opioid oxycodone, Vicodin or Norco, and that has the opioid hydrocodone. Heroin is diacetylmorphine. And for those in the United States who may not be aware of this, heroin is used as a medicine in the United Kingdom all the time. Okay, they don't call it heroin. We're going to give this patient with a kidney stone 2 milligrams of heroin, but they'll give diamorph, which is diacetylmorphine. So these are all similar compounds that bind the same receptor in the brain, the opioid receptor, and they can affect the short-term experience of pain by mildly blocking the transmission, but also elevating your emotional state, and so your suffering decreases.
Yes, so it has a physical relieving element as well as a psychological help as well, right? You said that it helps with.
Well, I would say everything's physical. Your psychological is very much physical. So it affects. It may be more difficult to visualize those effects on a CAT scan or anything, but it's all physical. But yes, it affects your emotional state, and it affects the actual signal strength.
Okay, so if you are taking the opioids and you're not producing the opioids naturally anymore, then you can become dependent on them, correct?
Well, yeah, what happens over time, like most everything else in the body, is that your body wants something called homeostasis. And that, for those in the audience who have taken biology, are familiar with that. And it's a very common term in medicine, which is the body doesn't want to do this, okay? The body wants steady, okay? So if you bring your mood up with opioids, your body starts to push back. It's like, it doesn't want, I mean, is maybe frustrating as it, elation and an emotion, that's not stable, okay? The body wants you to be more like meh, okay? So in the short term, it can do that, but your body starts to push back very quickly. And it stops making its own opioids in a similar way that a bodybuilder who takes testosterone, a professional who gets all big and big, his own body stops making it because the body is very efficient and says, well, why would I make this compound if I'm getting it from the environment? So it stops doing it. And the body also says, this is actually kind of too much. And it stops making receptors for it, and it stops responding to the chemical as much. And those in the field of opioids and pain research know that the brain develops what's called opponent processes, which means it very shortly after taking this compound, the brain starts to make counteracting compounds. And so the medicine has a less effect over time. And that's what, when you talk about dependence, that's where you can get that problem, because once the medicine wears off, now you feel actually more pain.
Yes.
And your mood is actually not kind of meh, but it's actually kind of down. It's like you don't feel good because your natural opioids, which kind of keep your emotional state, hopefully reasonable. I mean, again, you're not giggling all the time, but reasonable. You've depleted that. So now you actually don't go back to kind of your state. You're feeling down. And again, that's what happens if you use these compounds over a long period of time or in high doses. Your dip after they wear off is low. And that's when you have things actual withdrawal. And that's a state of misery that can lead to desperate decisions.
Yeah. So when doctors prescribe these opioids, it's for short term only, right? It's not something that they want people to be on forever.
Well, it was supposed to be. The problem we developed in this country in particular was that starting in the late 1990s, some doctors who were in the pain business and often paid consultants of the pharmaceutical companies that made opioids said, oh, why don't we can use this for long-term use, and we use it for back pain, we can use it for headaches, we can use it for joint pain, and made the case that these medicines were, you could keep using them for long-term pain reasons. And they did so without any studies showing that they were effective, but they had this sort of consensus statements, which experts will, you know, in the field will make, sometimes with good evidence to support it, but sometimes there isn't good evidence, but that's how they all feel. And that's what happened in the late 1990s. Now, what they should be using it for is, yes, short term, like you have a broken bone, or you have a kidney stone, or you have you know, an abscess, which is a painful collection of infection, right? You use it for a few days, maybe a week, you know, or maybe like a knee replacement surgery, maybe a couple weeks, and then you stop. Okay. And that's where they have their primary sort of beneficial effect, is get you through that really, you know, painful initial period. But then, okay, you stop taking them. Yes, you're going to have some pain, but as your body heals, that will also go away. The other place where opioids can be used kind of indefinitely would be end of life care for someone with a terminal condition, advancing cancer, in which case the risk of, I mean, yes, they may get dependent, but who cares?
Right.
Okay? At that point, you know, the reason you want to prevent dependence is because you don't want them to keep taking it and to maybe develop addiction. And addiction takes away all these things from your life, your ability to work, your ability to look after your family, your relationships. Okay. Well, if you have end stage metastatic cancer, that your disease is doing that already. I mean, you're not in a position where you need to go, where you can go to work and make your payments for your kids' college, or you're more like, well, anyway, so end of life care, it's like the disease process has taken that away already. Just focus on comfort. And if you need more, you get more. So in those stages, it's appropriate.
So just kind of rewind a little bit about the withdrawal that happens with people. Can you just go into that a little bit? What are some of the effects that people feel when they try to get off of it after, you know, they've been taking it a while?
If they've been taking it a while and try to stop right away, there's very, well, depending on how much and how long they've used it, a withdrawal syndrome, or sometimes called being quote unquote dope sick. And, you know, it has been described as quote, the worst flu you've ever had, which is you're sweating, your heart is being fast, everything hurts, your back hurts, your legs hurts, you're shaking, you may be vomiting. It can be quite a miserable experience, and you are maybe non-functional because of it. And so some will just, you know, person who may have been addicted to, say, heroin and using it IV, you know, their first dose of the day isn't to make them feel awesome. It's to stop that, okay, to sort of get back to almost a normal feeling. And that's the terrible part, where like when you have to use this to just get kind of back to baseline. But that is the withdrawal. Those are some of the withdrawal effects when your body has almost no opioid in it. You've depressed how much opioid you make. You've depressed how many receptors you have now, and your response. So now you're way below zero in that sense, and you're miserable.
So as far as treatment, my understanding is that you treat opioids with opioids. Can you go into that a little bit?
Right. So what you're trying to do with opioid treatment therapy, with medical assisted therapy, and by that I mean methadone, or other medications called buprenorphine or Suboxone.
What about kratom?
I'm sorry, kratom?
Kratom.
I'll be honest, I've never heard of treating opioid use disorder with kratom, but if some are using that, if there's opioid activity in that, and I don't claim to be an expert on kratom, I'll be honest.
Okay.
But the idea behind opioid therapy for opioid use disorder is that you are trying to replace the short-acting intense high with some level of opioid activity that is more, gets you closer to baseline at a sort of steady level, that reduces the withdrawal symptoms, reduces the cravings, so you don't do something rash and desperate. And a person who's going through that terrible withdrawal syndrome, yeah, they may go like, I need something, I'm out of my pills. They'll go to the you know, the black market, illegal market, you know, the extra medical market, buy something from somebody, maybe it's laced with fentanyl and they had no idea. And that's when sort of an overdose can happen. So or that's very high risk for that. I mean, you can have it, you can even on Suboxone and Methadone, you can still have an overdose, but it reduces the risk of that because you don't want someone in terrible withdrawals with terrible cravings with no recourse. You're trying to get them to enough level of opioid that they won't have that terrible syndrome, and over time hopefully reduce those doses of the methadone, the Suboxone, as the brain begins the recovery process. Now that can take some time, and maybe some will actually never get off that. But you hopefully the idea would be you replace those sort of more the opioids where you don't, especially like heroin or fentanyl, you don't know the dose, you don't know what's in it, with something that's very predictable, reduces the cravings, and then over time the brain is allowed to heal. And hopefully over time you can also taper the methadone and Suboxone so you don't have to take anything.
Okay, very good. So can you maybe touch on the populations that are most at risk for an opioid addiction or overdose?
Well, as I mentioned sort of at the opening, this disorder can touch anyone, okay? And, like I said, the typical or the historical at-risk populations would be those often in a place of sort of emotional distress and vulnerable. And that when you look historically at where the substance use issues have been, kind of like, the inner city, with lots of unemployment, with lots, kind of a hopeless situation where people are feeling bad most of the time. Okay. The opioid crisis began in this country more kind of in the Appalachia areas, where small towns,
Poverty.
not a lot of employment, boredom, and sort of not hopelessness, but kind of a sense of lack of purpose. And so you're missing that sense of connection, you're missing that sense of purpose. And if that's sort of every day in and day out, you are vulnerable to what intoxicants can do, which is, at least for a short time, make you feel better. Okay. Yeah. And again, inner city populations have been typically the ones that have the problems with more substance abuse. However, what I would say is, again, when I went to that suburban hospital in 2003, and over the next couple of years realized, man, it's everywhere here. Yeah. Okay. What we also know is that just being exposed to opioids for even as short as 2 months, you can develop a dependence and addiction. There was a very compelling study in 2016 from the Kaiser Foundation Washington Post study that showed in a survey of a bunch of people who are taking opioids, as little as 2 months. Okay, about a third of people taking opioids for as little as 2 months reported being dependent or addicted. Wow. So that's why, even if you say are a business person or a professional in a otherwise, a very fairly stable environment, and one that's not surrounded with other toxic, people and crime or whatever, even as little as 2 months, you can find yourself dependent or addicted. And now that's trouble. Okay. Yeah. So that's why you see the stories like, oh, this person had everything going for them. They were high-powered attorney, and then they injured their knee running, got a surgery. Next thing you know, or, a year later, they're in a hotel. Their family won't talk to them. And it's just a terrible story. So while there are vulnerable populations that come from, again, disadvantaged backgrounds, everyone is vulnerable. Everyone is vulnerable.
Yes. I found an interesting statistic by the Partnership for Drug-Free Kids. They said that prescription medications are now the most commonly abused drug among youth, 12 to 13-year-olds. Does that surprise you?
That's pretty young. I guess I hadn't seen that study, and I guess I can't see how they got that conclusion. What we do know is that prescription drugs are the most common way that people get introduced to opioids, period. Okay. Someone is recovering from a knee replacement, or someone had a broken bone and a cast, and they're looking for pain relief. Their first answer is not, I think heroin's the answer. I'll start making some calls. What they won't make that psychological leap to, like, that marketplace. Okay. Yes. But what they can do is like, well, it's a pill, It's made by a pharmaceutical company. It's a doctor who wrote for it or some other provider wrote for it. Can't be that dangerous.
Mm-hmm.
So they'll make that leap. Okay. And we know that 3 out of 4, we're actually 75 to 80% of people who eventually go on to develop a problem with opioids, develop opioid use disorder, they began with prescriptions.
Mm-hmm.
So it began sort of taking it for probably some, for some painful cause, and the prescription kept going,
Mm-hmm.
and they kept using it longer than they probably should have. And
Mm-hmm.
that's how the problem of dependence, which then can lead to addiction, develops. So they can make the psychological leap to a prescription. It's medicine. It must be safe. And then over time, like, well, I mean, I guess these other compounds, heroin's, it's about basically the same. I can get more of that for less money.
Mm-hmm.
And that's when they turn to those kind of substances.
Yeah.
But especially for someone 12, 13, they're going to find it in the house medicine cabinet. It won't be theirs.
Mm-hmm. Right. They're not getting prescribed it. Usually they're going into their uncle's medicine cabinet or something.
Yeah, their grandma's medicine cabinet. And, they're not going to, the doctor will not probably write for that I mean, it's a little young to get your wisdom teeth out. Later teenage, or like that. We do know that a lot of people get introduced to opioids when they have their wisdom teeth out. So there's more of them these days, like, hey, let's do just a couple days right afterwards. And then,
and that's it.
Don't keep going with that.
Yeah.
But overall, the idea that prescriptions are the sort of the kind of gateway is not surprising at all.
Okay. So let's look at this interesting statistic. More people died of overdoses in the United States last year than in any other 1-year period in our history. So according to the provisional drug overdose death statistic for 2020, more than 93,000 people died of an overdose. That's up 30% from previous years. So what do you think of that statistic and maybe some of the contributing factors why 2020 was such an issue?
Well, kind of what we talked about already. We talked about populations that are vulnerable. The pandemic from COVID made everyone more vulnerable. Okay. Mm-hmm. And I think of those 90 something thousand, 70,000 were opioids. Because opioids, and for those in the audience who don't know, the reason opioids are particularly dangerous is it affects your breathing. Okay. One of the things opioids do, besides controlling your mood and controlling some pain transmission, is that they affect your rate of breathing. And so those who die of an opioid overdose have so much opioid that it binds the breathing centers in your brain and slowed your breathing, that it couldn't get enough oxygen. And then you pass out, become unconscious. And in a few minutes, without proper oxygen, your brain dies. And that's how people usually meet their end with opioids. And that's not how they meet their end with this, cocaine and others more stimulant, can cause death in other ways. But the reason why it's much more dangerous with opioids is it affects how you breathe, and that death can happen within minutes, like that. But I'm not surprised to hear that 2020 was the worst year ever, because when we think about what makes someone vulnerable to the lure of intoxicants, all of that became worse in the pandemic. People were isolated. They didn't have normal human social interaction. And human social interaction is rewarded in your brain. You have a positive interaction with family, friends. You get a little hit of dopamine. You get a little hit of opioid. Okay, that you are rewarded for that. Okay. Yeah. Now you can only do it. Virtual interactions are okay. It's not like being in the present. We evolved to be in the presence of others. That is how this species evolved. Yes. And we're deprived of that. We feel that lack of connection. We don't have our normal opioid system, working. Plus in the pandemic, people face lots of other challenges. They might have found that their job was threatened, might have found that which threatens their, are they going to be able to eat? Are they going to be able to stay in their place? So they were facing shelter insecurity, food insecurity. They feared for their own health. This is a very deadly. I got COVID. Right. We also have seen that, like, the sales of alcohol went way up with COVID. So all those factors that make a human vulnerable to the allure of that became worse. Added to which, with the with COVID and the restriction on the new restrictions on how one goes about getting healthcare, there was a decreased access to addiction treatment.
Yep.
I think the primary problem was all the things that make people vulnerable got much worse with the pandemic.
Yes, yes. And all predicted, right? Like you could see that coming when it started happening with the lockdowns and restrictions and, putting people in unfortunate situations.
Right, on situations, and then then the added trauma of a fair bit of our political leaders not acting to make people safe. Okay, so
Yeah.
then not only do you have the crisis, but you have what looked to be abandonment by those who might be able to help you. And so those who in the mental health, who are focused on the mental health industry, the psychologists, the psychiatrists, talk of the next pandemic is a mental health one. That the effects of COVID have caused these very harmful, almost PTSD type of effects.
Yep.
And so you've got a pandemic of COVID and COVID death, and now you've got another pandemic of the mental health consequences of that.
Yes. So let's just kind of rewind a little bit. How did we get here? How did we get to 70,000 deaths in 1 year? So you had mentioned this kind of all started back in around the 90s, 95. Can you give us a little bit of a history and how we got here?
Okay. Well, if you look back at like when did we weren't talking about this in 1992, and I'm old enough to remember 1992.
Me too.
I wasn't a physician then. Actually, I was just, I had graduated from college and hadn't, was still trying to figure out what I wanted to do with myself. But in the early 90s and going back into the 80s and 70s, you did have people becoming addicted to opioid pain relievers. These medications had been around for decades. Okay, these were not new inventions. And in those times, it was fairly steady year to year. You had about 4,000 Americans dying of prescription opioid overdose and another 2,000 dying of heroin. And that had been fairly constant. That had been, so about 6,000 Americans with a plus minus year in, year out, were still having issues with opioid use disorder, dependence, addiction, and overdose death. What changed is that in the mid 1990s, 95, 96, the opioid manufacturing industry started their campaign that chronic pain, back pain, headaches, knee pain, other sort of chronic pain conditions could be safely treated with opioids, and that we were, our reluctance to use them was misguided, and we should be using them much more liberally than we ever had before. Up until the 70s, the 80s, early 90s, again, opioids were by and large restricted to short-term use for acute injuries, sudden injuries, and then for end-of-life care. And it was in the mid 90s with the introduction of oxycontin by Purdue Pharma that the campaign that pain is the fifth vital sign, that opioids are safe, they had gotten a bad rap, you can use them, that started to gain traction in the medical community. And it was traction not based on actually good evidence, it was traction based on the advocacy of some leading experts in the industry, experts often who are in the paid employ of the pharmaceutical companies themselves, and made handsome amounts of money leading this charge. Sadly, that was not backed by any good studies that showed they were safe, but rather they would publish articles showing case studies, which is a case study is, I saw these patients, they had these characteristics, they took opioids and they were safe. Okay. That's not very helpful in terms of like deciding for a new treatment. Okay. Yes, that's interesting. You had these patients, maybe from this background with this condition, they could take opioids and they never seem to develop addiction. Okay. All right. Well, you can find any number of people who smoke cigarettes. Look, they smoked cigarettes for 20 years and they never got lung cancer. Okay. You can find plenty of that. So when you have what these quote case studies or case examples, that's what's called an observational study. And an observational study is useful, but it suggests you should do the follow-up study and do a large number of people and follow them over time to see if this works. And you want to do it in a controlled, blinded way, which means neither the subject of the study or the experimenter knows who's getting what treatment. And that's a proper scientific study. That was never done. So what you had was these experts who are paid advocates of the pharmaceutical industry arguing for broad use of opioids without any studies. And just over time, that became standard of care because they're, well, like in many fields of study, you kind of defer to the experts. You're sort of quote unquote teaching faculty, students and professionals like myself. You can't go and, you have to have some level of trust. You can't go through medical school and say, I don't believe this study, I got to go do it myself. I have to, repeat every study in biochemistry, physiology, cardio. You can't do that. So in a sense, you do have this filter that, okay, the people at the top of the industry, the leading academic institutions are acting in good faith. They wouldn't report this unless they had good reason to, okay? But they didn't. And they made statements about how very few people became addicted, the less than 1% become addicted that I mentioned in my TED Talk, which was not based on science. And so starting in the mid-1990s with OxyContin, this pain is the fifth vital sign, chronic pain is an undertreated epidemic, these medicines are safe, you can use them indefinitely, became the culture of prescribing in medicine. And what happened starting in the mid-1990s to the early 2000 or to the mid-2000s to 2010, prescriptions tripled or close to even quadrupled.
Wow.
And it wasn't just the number of prescriptions, but the amount of opioid in each prescription increased as well. So you had this dramatic, maybe 8-fold or even 10-fold increase in exposure of the United States population to opioids. And as we saw in the Kaiser study, it only takes a couple months before a great many find themselves dependent. So if you're going to treat chronic pain, well, it's going to go more than 2 months. So you created this entire population of people who found themselves a year into it, like they couldn't stop. So, and that's what changed is the agenda of the pharmaceutical industry and their, I guess, business savvy, kind of medical negligence on the part of the physicians who signed up and made those statements, and they should know better. Okay, I don't have much patience for any physician who says, well, if we had only known now, we'd known then. Yeah, okay, but you knew what kind of study needed to be done to show it was safe. That's basic biology. That's basic. Any medical student will get taught population health and biostatistics. So yes, you may not have known opioids over this long at that time, but you certainly knew what kind of study it took to prove your point, and you never did it.
Yes.
So that's my main criticism with the medical industry is like, yeah, but we have mechanisms in place that you don't just like, well, let's try this on the patients and see what happens. You know what you need to do first.
So profits became like the leading driver of all of this with them.
Yes, and the medical industry in the United States is over $3 trillion in revenue. I think it's like the US medical industry is like the 5th largest economy in the world. So yes, when you have $3.5 trillion moving in this, science can be corrupted by finance when you have that kind of dollar value.
So that's interesting. Let's talk a little bit about that pain threshold that people have. I had an accident a couple of years ago. I was in the hospital and I had a really good nurse that made sure I felt no pain. I mean, the whole time I was in the hospital, she would always ask me what your pain at, and I never felt pain in the hospital. But as soon as I left the hospital, there wasn't much education. They gave me the pain meds. I did take them for a few days, but I didn't want to take them much longer because one of the side effects was constipation. And I was like, I don't want that. And, but it was an interesting thing to kind of go through the system of how liberal they are with giving you the pain medication and not having much education behind it.
Well, one of the other, what a part of this campaign about pain is a 5th vital sign, chronic, pain is an undertreated epidemic, was there was this movement that any pain a patient felt was almost tantamount to negligence or medical malpractice. Okay. And part of the campaign became like, that's when the sort of the 0 to 10 scale started appearing in every hospital room, and every room in the emergency department was, what is your pain level at? And you were required, okay, to ask the patient what their pain level is. And hospitals were graded. Okay, hospitals have what's called an accreditation process by something called the Joint Commission, okay, or JACO, or at least it used to be called JACO. Maybe it's just the Joint Commission now. And one of the categories that a hospital would receive its accreditation, which has a significant dollar value attached to it, is pain scores. And so hospitals are graded on the scores the patients give them. And the closer to zero they get, the higher their rating, the more revenue that meant for the hospital. And so their incentive to get your pain down to next to nothing while you were there would affect how if you were one of the people who got a satisfaction survey afterwards, you would give them high marks for that. Yeah. And that's what their incentive was. It wasn't necessarily for your long-term health. They want a nice, customer review is what they want. I mean, it's a customer review.
That's interesting.
The better the customer review you get, that actually does translate into higher levels of reimbursement. In fact, that's in the ACA. That Medicare reimbursement is tied to your performance on these satisfaction surveys. And while you don't want people to be unhappy, but you don't want to compromise, care and go against the best science in order to achieve that. Okay? Yeah. It is not the patient's job to know what the last 20 years of research in this has been. How is my treatment aligned with that? This is just how they felt about this. So when you make actual medical care decisions based on, well, how are they going to emotionally respond, you get into trouble. And that was a big problem in the industry. I don't know if they still have that as the driving force, but that is one of the patient satisfaction questions is about pain. And so that's why they were like very aggressive. And once you were out of there, you're on your own. Okay. They're focused on you reviewing them for that visit. Yeah.
Which is real interesting.
It's a good thing you stopped after a few days, like we said. Yeah. Don't.
Well, pain is such a subjective thing to think about, because what I might see is, a 3 on a 1 to 10 scale, you might say is a 7, and so it's very subjective on how people deal with the pain.
Right, and pain is subjective. Pain is very emotional. I mean, all of life is emotional. Okay, emotions are far more than a detached cost benefit analysis of, should I go to the grocery store today, or do I need to do this today? You sort of like, I feel this, therefore I will go do this, go to the store. I will buy this. I will, so go see a friend. It's like your emotions are the primary driving force of why you do anything. Why anyone does anything.
Right.
And so pain is part of that, and pain is a very emotional one. And we have seen why someone whose life is a lot of distress, their emotional state needs elevating a lot of the time. For many people, like, every day is one long emergency. What increases the risk for chronic pain is, say, someone who may not have a job, or maybe they've got 2 jobs and they've got no childcare, and they've got no benefits. So they're struggling. Okay, they're kind of financial straits. They maybe struggle with anxiety, depression. The number of people who have been prescribed opioids who have a co-diagnosis of anxiety and depression is extremely high. Okay, that's one of the because it does have this mood elevating effect. And so it's not just the pain that sort of gets relieved, but it's their emotional state from minute to minute. Okay.
Yes.
That doesn't last, but that's why it has this effect. And that's why factors that increase chronic pain would be, again, perhaps employment problems, childcare problems. As you have your place to stay is kind of tenuous, and maybe it's unsafe. All of those factors that increase stress increase your experience of pain.
Definitely. So in 1995, seems like we went an extreme route by overprescribing. Now we're in 2021. Has it gone the other way, or are we balanced out with regards to prescribing practices of opioids?
We've come down a bit, but I mean, we've come down by about 25 to 30% since around 2012. I think 2012 to 2014, we had sort of hit the peak amount of prescribing of opioid pain relievers. Now we've come down about 25 to 30% since then, but we have not gotten down to 1990. We've still got a ways to go before we come down. We have to go back. We have to cut back around to 75 to 80% more of what we have now to get down to those levels. Okay.
Right, right.
But the
Yeah,
problem is, right, the problem now is that in that time period where we dramatically increased the prescribing, we created this whole population now that developed dependence. Okay. And that is why you're seeing, as the prescribing, comes down gradually, those patients who've developed the dependence may be turning to sources outside of the regular medical marketplace for their opioids. Okay. And that's why you're seeing spikes in use in heroin, spikes in fentanyl, because those are compounds that, again, you developed addiction, you developed dependence or addiction with years of taking the prescribed opioids. They're trying to get you off them, but you're not, and you might, and some doctors may unethically totally cut someone off, which is not ethical. It's not safe. A person like that might then turn to that marketplace. Okay, so they became dependent or addicted on prescribed opioids, and then they transition to heroin. They transition to pills bought outside, the pharmacy, which again, they don't know how much. You never know how much is in it. You don't know what else is in it, and that's why you have the spikes in the fentanyl. Right,
right. So as far as people with chronic pain, how are you handling that situation with their opioid, prescription plan?
Right. Well, it should be remembered that some patients with chronic pain are not on chronic opioids. Okay. So you have the chronic pain patients who have so far avoided opioids. And for them, we know that the treatments that are most effective are the ones that the patient can maintain agency and are sort of proactive in their treatment, which is to say, they feel control over their pain, and they're doing things like exercise. They're doing, we don't also know that weight loss. If someone is significantly overweight, that's added pressure on the structures in the back. So weight loss, exercise, also mindfulness, when they sort of practice a sort of centering type of technique in yoga and meditation to affect their emotional state when they respond. Not that the pain is there, but how they respond to it, they develop some control over. And those patients who are doing that for their chronic pain, they live. Okay, remember, chronic pain's still been around. It's like we just lived with it without opioids.
Yeah.
Okay?
We had other
preventative.
Right. There's other preventative tools, like you just mentioned. Yeah.
And I one of the other criticisms I have of the entire medical industry is we've sort of promulgated, and you see the commercials on television for these drugs that'll help you sleep, that'll help make you sexually active as an 18-year-old, that, it would be that health is absence of any symptoms. That's not health. Okay. Maybe you've got no symptoms, but you have those windows in life where maybe you have no symptoms of anything. Maybe. Okay. Health isn't that. Health is you're able to live and function and work if you're working, and nurture your relationships. You can do all that with symptoms. That is health. Okay. I don't know many people who are totally symptom free. Now, what do we do with the people who have chronic pain who are on their opioids? Well, if possible, it would be best, because we do know that opioids are a risk factor for overdose, if we could get them off. Okay. And so for those patients who are willing and are in a position to do it, a taper is recommended. And a taper can be very gradual. And any ethical provider would talk to their patient about, like, okay, here's what we want to do. Try to get the patient engaged and get them to do a taper. And they might even be only like 10% per week, maybe 10% per month, but continue that taper so they get the levels their opioids are taking down to safer levels, or in some cases even stop. And the patients who actually get off them altogether report they feel better. Their life is better now. For some, you might be able to taper partially, but then going below a certain level is sort of challenging, and you just might keep them there at a stable opioid dose, and just never go back up again. Like, yep, this is the level you're gonna be at. I guess we're gonna stay here. And for some, the best you might be able to achieve is stop the process of dose escalation, that they just say their pain is worse. Okay, we're gonna add 10 more milligrams. And then they say, well, I injured my back. moving some furniture, or I got into a minor car accident, now my pain is worse, and then the dose goes up and then just stays up. And that's what happens over time is painful things will happen to people all the time. And then that
Right.
they'll go to and then, okay, well, now I guess the new dose is this, and then something else will happen. And then, well, the dose now goes up again. And so that over time, the dose keeps escalating. Well, what hopefully we can at least stop that process. Now, maybe you get a couple of days for an accident, a minor one, but like you're going back to that level dose. You're not going up and up. And then there's some evidence that those who have who are on chronic opioids for chronic pain, that even the addiction treatment drugs of methadone and Suboxone, you might be able to use those. So even though they haven't developed sort of the, what characterizes addiction is not just that they need the opioid, it's that they'll have, what characterizes addiction is also the behavior. Like they keep going, using the opioids even after they have an overdose, or after they get in a car accident, or even after using opioids, they lost their job. It has this behavioral component that they're acting, unsafe things are happening, they're acting in, against their best interest, and they're using anyway. So addiction has that. Well, chronic opioid use for chronic pain, well, they don't have that part, but they're using opioids all the time and trying to stop, create some withdrawal, okay? There is some evidence that using the addiction medicines of methadone, Suboxone might help those patients too. So, and I would put that under the same categories. If you get a person who's on chronic opioids, at least to a stable dose where they don't have to keep going up and up and up.
And you had mentioned earlier that, some populations will turn to like street drugs if they can't, have healthcare access or afford prescription, or for whatever reason, they might turn to a street drug like heroin that might be laced with fentanyl, and then, or other things that people die of an overdose in that situation. What are your thoughts on that?
Right. So well, in general, okay, even someone who does have access to treatment and is taking Suboxone, we have studies showing that even half of those patients will continue taking non-prescribed opioids. Okay, so Suboxone and Methadone are valuable, but they are imperfect treatments. Okay, it's not like a diabetic who is no longer making insulin and now gets insulin through a medication and basically can lead a life of normal life expectancy or otherwise close to it, because that needed chemical, that needed protein has been supplied, okay, by the medical assisted treatment helps take away some of the worst effects of opioid withdrawal to keep someone from overdosing. But, once you develop opioid use disorder, your life is shortened, okay? Not just from overdose, but all the things that go with opioid use disorder. And that also includes things like heart disease. That includes things like trauma. That includes things like infection and hepatitis and all. If you get into the realm of a use disorder, it isn't just the substance that affects your health, it's all the stuff that goes around with it, okay? And we know from studies in addiction medicine that someone with opioid use disorder who's even being treated, the risk of death every year is like somewhere between 1.5% to 2%, okay? Now that doesn't sound very high, but if you look at the life insurance tables, that's a 65-year-old. So even being treated, you are not, it is not like you got cured. It is not like your risk is now back to what it was before, okay? So what I would say about methadone, Suboxone, and these treatments is, yes, that it's better than unmanaged, unstable use disorder, but it is no substitute for like never getting in there in the first place. And so that's why my focus at the Department of Human Services here in Minnesota, and what I would hope elsewhere too, is we need to focus our efforts on, or one of the focuses needs to be preventing someone from progressing to that in the first place, which means, again, being very careful if someone has a surgery, if someone has a fracture, like, yes, we're going to take care of your pain in the short term, but we're just not continuing with these medications. And we're actually going to, here in this state, we're actually following doctors' prescribing. So like, if a doctor is showing that they keep putting patients on new doses of opioids that's very high, they're going to have to answer to, the Department of Health. So what I would say about those treatments is they are useful. They are better than not being treated, but no one should feel It's not the cure that taking an antibiotic for a bladder infection or taking insulin for diabetic is. You
Yeah.
still can develop the sort of the change in your brain pathways and physiology with
Mhm.
years that those
Mhm.
treatments help sort of control the worst aspects of, but
Yeah.
it doesn't cure it.
It reminds me of, the term people throw around, functional addicts. Like, he's a functional alcoholic, but he still shows up at work. He pays his taxes. He shows up and takes care of his kids. And he's a functional opioid addict. And that might be true, but the body always keeps score.
Correct. And while we're all trying to be functional, maybe we all have our
Definition of
maybe
function.
unhealthy indulgences that sort of keep us together from day to day. But yeah, and while function is important, it is no because they're functional until they're not. Okay,
Yeah.
and so that's the issue. Like, saying someone is functional is like, they're a smoker without cancer until they're a smoker now with. Okay, so
Yeah.
what we know is that with a person who is taking high doses of opioids per day, their risk of overdose and the risk of dependence and addiction goes up over time. So it's a very important thing to understand that exposure to a risk factor itself needs to be controlled and treated, even if you haven't developed the condition yet. Okay, in the same way we talk about tobacco smoke and cancer, that's why we want to stop smoking before we get to that.
Right. Are you familiar with Dr. Carl Hart? He's a neuroscientist at Columbia University.
I can't say that I am. Maybe you could educate me here.
So he is an interesting fellow. He wrote a book, Drug Use for Grown-Ups. And he's researched drugs for like 30 years, written 100 scientific papers. And he's really big on decriminalizing drugs and kind of having a libertarian stance when it comes to drug use, that people, are grown-ups and should be able to use drugs, including heroin. And he thinks that, for example, like in the United States, we need to have clinics where people, like drug users, can come and test their drugs and make sure that the heroin is pure. Like in other countries, they have that available, but in the United States, we don't. Is that something, if you're looking at future policy making, is that something that you would get behind, or do you think that's a bad idea?
What I would certainly say is that treating the drug problem as a public health issue and less of a criminal justice issue is very much needed. Okay, and we have other experiments on a national level. For example, Portugal, about a decade ago, decriminalized drugs for personal use.
So did Oregon, the state of Oregon.
And if you want to compare country to country, like Portugal has fewer overdoses on a per capita basis. They have fewer treatment admissions per capita. I mean, the United States has the highest rate of drug overdose in the world. Okay, and we have some of the strictest drug laws. Okay, so you can't rationally look at, just prescribe it in a law and say you're going to go to jail and make a criminal offense out of it, and think like the population is going to be okay. Well, I guess we just won't do that. Okay, that's a very simplistic, even juvenile way of looking at this problem. Okay. You should treat drugs as a public health issue that you want someone to, and remember, decriminalizing doesn't mean we're saying, oh, it's okay.
Right. And he doesn't say that either. He's just saying,
and we're not saying
going to do it.
And we're not saying it's unhealthy. Okay. But in many respects, like, we'll take a more easier example, like say marijuana, for example. Okay. There is no scientific reason that marijuana is illegal and tobacco and alcohol are. Right. They talk about the dangers to kids who smoke marijuana. It challenges their ability to develop. And that is all true. Okay. That's true of tobacco. That's true of alcohol. In fact, alcohol is actually quite a bit more dangerous than marijuana. I mean, as far as I'm aware, no one has ever died of respiratory failure from marijuana. About 2,000 Americans every year die of respiratory failure from acute alcohol poisoning. And that doesn't even account for all the deaths that correspond to, say, traffic fatalities where alcohol was a significant contributor, or the toxic effects of alcohol on, say, someone's liver. So we're not saying that any of these substances are healthy, but to add that level of criminality to it is often not helpful.
Right.
I guess I don't know all the studies about saying, having a safe injection site, but, you should make policy and make laws in terms of like the social cost. Okay. And also understand like a healthy person, if you want to go do meth, you can go do it. Okay. It's just that a healthy person doesn't get off work and say, well, it's a tough day at work. You know what would take the edge off? Meth. Okay. That's not what a healthy person does. Okay.
Right.
So understand that if you made meth legal tomorrow, you're not people who feel like everyone's going to go, no,
Right.
that's not what a healthy person is going to go do. Okay. And like I said, you had this massive increase in overdoses during the pandemic. It's like, understand what drives someone to use or not use isn't whether they see a law. It's what are they feeling and what are their stresses, what are their vulnerabilities.
Right.
So I definitely favor a public health and science approach to the drug laws, and understanding that just saying something is forbidden is not a great way to control human behavior.
Right. You have to meet people where they're at. And if people are already using it, they're not going to change overnight. And I think
and then you can use that, right? And you can use maybe a program like that as an outreach. Do you want to stop? I mean, some say they don't. Others would say like, I do want help. I mean, this sucks. Okay. For a person who's in the midst of all that, like every day is like, that's all they do.
Right.
Where do I get another prescription? Where am I find this next dose? I don't want to go through terrible withdrawals and feel miserable.
Right.
That's a sucky place to be.
Right. Right.
And so you're gonna reach out, be able to talk to them like, well, let's try and help. Here's what we can do. So use that.
Yeah. So if you were a policymaker, and you had a wand and you could change things in our laws or in our healthcare system to combat this, what would you like to see done?
Well, what I would like to see done, well, there are a couple things. One of the other, with my particular field which is medicine, not only do we have the historical example of prescribing opioids for these chronic pain conditions and not having proper scientific evidence, is I would want to see my profession become more scientific. And one of the ways you make it more scientific is you start severing these relationships with industry. Doctors are humans, even scientists are humans, and their conclusions can be very much clouded by what's in their financial best interest. So let's take away some of that incentive of their own financial best interest. We had a very compelling study published in the Journal of the American Medical Association that showed, when they looked county by county, where there were more pharmaceutical company gifts to doctors, there are more opioid prescriptions and more overdose deaths. So let's create something of a firewall between pharmaceutical industry and physicians. And doctors are also, like humans, they're not good at being able to recognize when their behavior is being affected. So, they'll say like, oh, I took the money, but it doesn't change anything about how I practice medicine. Well, no, the studies repeatedly show that it does. Okay. So we need to create a safer, more scientific medicine that doesn't have this financial incentive. So I would create barriers there. And hopefully what that would do is decrease the rate of new chronic users. And by that, I mean, understand how quickly someone can become dependent and stop the prescription for opioids after a new injury, right away. The other thing you have to do, wave a wand, if I could, is make treatment available on a wide, make it much more inexpensive and accessible for everyone who needs it. Okay. Still only a smaller, a much less percentage than those who need it get access to medical treatment for addiction. And we need to make that, again, I've said that Suboxone and Methadone are not cure-alls. Okay. It's a very imperfect solution,
right?
But it's better than unmanaged opioid use disorder. We need to make that more accessible. And honestly, to that end, it's like, I don't see how a private revenue-driven industry can do that on its own. We need to have some level of intervention, either on a national level to control the cost of healthcare, so we don't have these people who are priced out of it and don't have access to care. And I would follow other examples of other countries, and you could sort of start decriminalizing, at least for personal use, and use it as an outreach for those who are struggling, to make sure that they're not using tainted chemicals. Okay, to make sure they maybe understand their dosing better, and use that as a time to like, do you want to get out of this? Do you want help with this?
Yes.
Okay. Again, we look at other countries that have taken such measures, at least, you know, not, they haven't decriminalized trafficking. Okay. Portugal did not, they haven't set up shops where, or like, they've said for personal use, they've decriminalized it. So, so I wouldn't decriminalize trafficking in those, but for personal use, for sure. And honestly, maybe it's a little controversial, but I would, yes, I think the fact that marijuana is illegal is you know, is completely incongruous with making alcohol and tobacco legal. So if you're going to make those substances legal, you should make marijuana legal for sure.
Is there any culpability or lawsuits needed?
For
the deaths, the opioid addictions and crises?
I definitely think accountability is needed. Unfortunately, I'm not sure. I'm not sure it's going to happen.
What's done is done.
Yeah, what's done is done. As the recent bankruptcy filing for Purdue Pharma that just happened in the state of New York, there will be, you know, the Sackler family had their billions protected. The bankruptcy court did file a judgment. They are going to pay some level of $1 billion over the next 18 years, which is a pittance compared to what they were bringing in for the last 25.
Yeah.
When your drug makes $2 billion a year times 20 years, and you pay like, no, that's paying a fine for doing something unsafe is not just the cost of doing business in the industry. I would like to see executives go to jail. I mean, fines for big companies. Okay, we wrote a fine. It doesn't make the population safer. You know, if you're really going to disincentivize companies from acting this way, you need to hold the executives accountable, take their freedom away. That'll make them think real hard that their money can't insulate them from real consequence. I would also hold the doctors accountable, especially the ones who promulgated this treatment and there was no evidence supporting it, and they would know better. They don't get the excuse of, oh, like you know, who knew that was going to happen?
Yeah.
Well, maybe you didn't know everything that was going to happen, but you knew what real scientific evidence was going to look like that said what you're doing is safe. And I would definitely have clawback features for the kind of money they took from the pharmaceutical industry. And I would actually hold some of them perhaps criminally accountable, or certainly malpractice accountable, for patients who had overdose deaths under their care.
Very good. So we're kind of coming to the end of our talk. Do you have any like last minute thoughts or ideas that you'd like to share on this topic?
Well, I guess one of the things I would want to, you know, first of all, thank you for inviting me again.
Thank you for coming on.
I didn't set out in my career to become an advocate. I mean, basically just wanted to do my career, and I sort of fell into this. Like I saw this problem that was causing all this suffering, and I felt I had to do something. I thought that was part of my job as a physician. Is like, well, you can't just ignore this, you know, and just do your job and go on vacation and do all the professional stuff that people like doing. Not that there's per se anything wrong with doing those things. I sort of fell into this, and so did so many people who became dependent or addicted. Okay. And I want to emphasize, this is about physiology. This is not a moral issue. And those who say like you just made bad choices, well, all these things, whether you were exposed to opioids or you're exposed to these crises in your life, that affects your ability to make good choices. You don't just get to start where everything is sort of level and you get to make this choice or not make this choice. The body reacts to things that affects how much your executive functioning works, like in thinking long-term, well, let's think about this before I do it. Things affect you. So for those who found themselves in this, I want to say that, you know, do not beat yourself up about it. Okay. When the medicine stopped working over time, that was just how the body reacts. That's physiology. That wasn't your character defect. That wasn't a moral failing. I actually have I have a great deal of discomfort and even antagonism to what's often seen in the recovery industry, is looking at it from that moral standpoint. I mean, the language about recovery in the traditional setups is filled with moralizing language, which I think is damaging, and it's not scientifically valid. And we've shown that over the years, as we've demonstrated other species become addicted, from chimpanzees to rats to birds. Okay, we don't talk to those species about their moral failings. Okay?
Right. Yeah.
We need to end that kind of discussion. That is not appropriate.
Yep.
So that's what I would say is, for those who fell into this, give yourself some, you know, reach out for help. Do not beat yourself up. and get the treatment you need. And for those who, again, for those who haven't gone down that road yet, understand how potentially addicting these compounds are, and know that you don't want to go down. You don't want to go down there. It can happen to you. It can happen to everyone.
Very good. Nicely stated. Well, thank you for being on my channel. I do appreciate you taking the time to be here today. And
thank you very much. I'm happy to have it again sometime if circumstances come up. Please make sure that those who view have my website where they can contact me if needed, and watch my TED Talk. I need all the views I can get.
I'll put it down in the description box down below. It was from a couple years ago, and it definitely needs more views because it was.
Yeah, and the stuff I talk about is still valid.
Yes. So if you guys like this video, please sure and give it a thumbs up, and don't forget to subscribe and hit the bell to be alerted to when the next video drops. Thanks for watching. Thank you, Doctor.
You have a wonderful day. Take care.
You too.
Bye.